큰 국가 정책이죠, 미국은. 한국은 그렇지 않습니다. 아직까지는
네.
이런 거에 대한 것은.
교수님 강의 오늘 듣게 되면 이제 많이 바뀌리라 생각이 들고요.
네.
그 시간이 아마 돼서 김태 교수님께서 여기 아마 진행을 해주시고 간단하게 아마 인트로덕션만 하면 이제 강의를 듣고 중간중간에나 이렇게 채팅을 통해서 질문도 올리고 그러면 강의를 조금 뭐 아주 길지 않게 한 45분 이내로만 해주시면 저희가 디스커션도 좀 더 많이 할 수 있고 그럴 수 있을 것 같습니다. 김태 교수님 그러면 진행 좀 부탁드려도 될까요?
네, 지금 참 그 한국 분들이 대부분인데 예, 영어로 진행을 일단 하도록 하겠습니다.
네, 유튜브에 올릴 겁니다.
유튜브에 올라야 되니까. 네. Okay, so welcome to colloquium series, second colloquium series. We are we have a very special the speaker today, Professor Seog Bae Oh. He is now the professor in the Department of Neurobiology and Physiology, School of Dentistry in Seoul National University. He graduated the College of Dentistry in Seoul National University, and he got an MS and PhD in the same university. And also he have done postdoctoral fellowship in the Department of Neurobiology and Pharmacology and Physiological Science in the University of Chicago in USA. And then he has been working in the University of Manchester and University Harvard Medical School as well. And then he is the one of the leading scientists in pain research. So it is a great honor to introduce him, and this will be the wonderful opportunity to learn about his science. So please welcome Professor Oh.
Thank you for inviting me to this pain colloquium. It's my great honor. Today I will talk about the peripheral neuroimmune crosstalk and how can we apply this mechanism to develop immunotherapy for chronic pain. You may know the pain is one of the main issues in not only in the medicine, also in the neuroscience. Then people actually suffering from pain, especially the chronic pain. Chronic pain is very intractable and very difficult to treat with the current analgesic. That's why many people in the neuroscience field working on the pain study. As you see here, this data show the report from the Pharm RMA report in USA. It was in 2015, but it is not recent, but the trend is about the same, I think. Data show the drug development in the neurological disorders is now applied for drug development in the FDA in USA. As you see here, you can see many of the familiar neurological diseases like Alzheimer, ALS, Huntington, multiple sclerosis, Parkinson, and stroke. And among these diseases, you can see that pain and headache, including headache, is all the many drugs currently under development for the pain treatment. Still, we don't have any specific new drug so far. That's why we need to study the pain mechanism in the product. Then current pain treatment, as you see here, for the mild pain, the doctors in the clinic, they describe the enzyme. like the Tylenol or the aspirin. Even you can buy this drug in the drugstore. But for the severe pain, it's like the chronic pain condition. The enzyme doesn't work anymore. That's why the doctor prescribe the more potent analgesics like the opioid, morphine, or like very, but it has the very serious side effect. For example, anxiety, as you see, it's quite commonly used for the people in everyday life, right? Then it's the very serious gastric the disturbance, the side effect. We should be very careful when we're taking this medicine. But the opioid is more serious side effect like addiction and tolerance. And then in the USA, as you see here, in 2016, about 50,000 people died by the opioid overuse or misuse. It means that the people, the doctors in the USA is prescribed more frequently than in our country. That's why also the USA, people believe that the white Caucasian is more susceptible to the pain. That's why they cannot, they don't want to suffer from pain. That's why they need some medication. And that's why doctor prescribe it often. That's why it happened. Then the Trump administration in 2017, they announced the opioid crisis. And they now invest a lot of money for the pain research and to develop the non-opioid analgesics. And then they want to reduce the number of the deaths in USA. But in Korea, not that serious, as you know. Then how can we find the new analgesics? Then people in the pain research field, they think we need new target for the pain. And we need to understand what's going on in the pain condition. Then people, even many doctors, right, in the clinic, they think that the pain is just a symptom, not a disease, just a symptom or sign. That's why they don't want to care pain in primarily. They focus on the disease first. Then they think the pain will goes away. But in many conditions, especially for the chronic pain conditions, they still suffer from the pain, even the disease goes away. That's the problem. We don't understand what's going on in our body. We need to understand. That's why we need to understand the mechanism rather than the symptom, right? Then how can we understand the mechanism? This is the review from the Dr. Clifford Wolf. Is the big name in the pain field in the world, and then he wrote this review in about 20 years ago. Still, the situation is about the same. Then we need still understand the mechanism going on. Then this is the snapshot from Cell Journal. This also about 10 years ago. This is the pain transmission pathway. This slide shows that the transduction, how the nerve fiber detect the pain signal in the peripheral of terminal, and then pain signal transmit the spinal cord, and transduction transmission, and then this pain signal goes to the brain, and we perceive the pain in the brain. Then also pain can be modulated in the spinal cord. That's why the opioid or other the drugs can affect our pain. Then we can target either way, even the peripheral tissue or spinal cord or even the brain. Then some researchers in pain field want to target the brain now. The people believe that chronic pain condition, something happen in the brain, then the plastic change happen in the brain, then we should target the brain. People argue for that, but I don't totally about them, but still many people want to focus on the brain. Then in my lab, we are studying the pain mechanism, as you can imagine. Then this is my research area. The mainly I'm working on the peripheral system rather than the brain. And that's one topic I will tell you today is the neuroimmune crosstalk in the NK, especially NK cell. Also, I am in the dental school. I'm a dentist, and I'm also interested in the tooth pain and the periodontal pain. I'm working on this too, but I don't tell you about this one. Then what about this neuroimmune mechanism? Before go on that topic, I will talk a little about the neuropathic pain. You may know about the neuropathic pain. Neuropathic pain means that pain resulted by damage or the disease affecting nerve. Usually pain caused by the affected nerve damage. It's like the serious problem in the patient. The most suffering pain in our body is the neuropathic pain. And in many cases, it's gradually goes to the chronic pain and quite intractable for current therapeutics. Current therapeutics is, as I said before, enzyme or morphine, or even many doctors prescribe antidepressant or the anticonvulsant to treat the chronic pain. It's not the pain drug, but they use that because it works, some people. Because in many the pain patients, they suffer from like this depression or anxiety or the CNS problem. That's why they target this CNS area. Then they can the symptom can be reduced in this chronic pain patient, but it doesn't actually target the pain source. The real problem in our pain research, we need to understand what's going on when the pain is damaged, especially in the peripheral nerve. That's why I'm interested in the immune response to the nerve damage in the peripheral nerve system. The peripheral nerve is innervated in our skin. Then it goes to the spinal cord like this. Then the peripheral nerve damage can result from many conditions like the surgery, even surgery, right? Then or infection, diabetic neuropathy, diabetes, cancer, or toxin trauma. In many cases, it causes the peripheral nerve injury. Then peripheral nerve is very different from the central nerve. As you know, central nerve doesn't regenerate, but peripheral nerve can regenerate. When injured, peripheral nerve can grow like this, grow, then try to find the original target. During this process, many the immune cells recruited, then they can grow. This is kind of adaptive response in our peripheral nerve system. But the problem is that during this process, the sensory dysfunction happen, like the pain. That's the problem. We think that this is the maladaptive process in the peripheral nerve system. Then why it happened? And what the immune cells doing in this condition? People is working on tuber cell, macrophage, T cell, or in many the immune cells here. Then in my lab, you are interested in the NK cell. This is I think it's the first report in the pain field to show that the NK cell involved in the pain, neuropathic pain condition also can be targeted by for the treating the chronic pain. Then why we target NK cell? Then I will tell you the reason. Then as you may know, NK cell is widely known to kill the cancer cell, right? The cancer cell or the virus infected cell. This is the non-self cell. Then NK cell target the non-self cell, missing the MHC1 molecule they can target. Then they kill. They want to remove the abnormal, aberrant cell in our body to test the NK cell work in our body. But what they do for the nerve cells. Then we researched the paper, then we found one report 2000. Then NK cell can directly kill the DLG neurons. This is the embryonic DLG neuron, not adult DLG neuron. They co-culture together NK cell and then DLG neuron. And then this is a very beautiful the DLG neuron culture. They found that NK cell can lysate, kill the, you see no right here, right? Then we found this paper, then we think, something, NK cell can do something for the neuron cell in the system. Then we researched more clinical paper. We found that in the peripheral neuropathy patient, they show the NK cell infiltration in the biopsy, nerve biopsy, in the peripheral nerve injury, the neuropathy condition. They can find something. Then we got some clue. Yeah, we have some the reason to study NK cell for this work. Then we studied about 10 years and then published our result in the Cell 2019. This work was commented in Nature Immunology in the same day. Then potentially our find can be used to develop the new painkiller. Then I will present that data today. And first, we want to confirm the previous result in vitro condition, whether NK cell kill the DLG neuron or not, and in vitro condition, and then we isolate the NK cell from the adult mice. Then we can isolate. Then we can isolate NK cell from the spleen, then purify over 90%. And then we can also activate NK cell by interaction stimulation. This is kind of cytokine. We can activate. Then we are not immunology lab. We are just neuroscience lab, and we took so long to work. But anyway, then DLG neuron culture and the NK cell together, and then see what happened. Then this is adult DLG neuron, 24 hours, less than 24 hours, acute culture. You see here. Then we co-culture with NK cell. There's some change, but not dramatic. Still, we see the right here. Then we did the this is embryonic DLG neuron, right? This is the degeneration. I'm sorry, I did miss some fragmentation here, right? Fragmentation. But adult condition here is almost the same, quite resistant to the NK cell. Then we did the LDH, the toxicity assay. Embryonic DLG neuron is very susceptible to NK cell. We increase the NK cell number, we see more the cell cytotoxicity, but it doesn't happen in the adult DLG neuron conditions. Then NK cell can target the embryonic DLG neuron, not the adult DLG neuron. Then we co-culture together in the same tissue. They can degenerate and kill the sensory neuron, but we put the NK cell in the trans well, in the separate well. They don't kill the DLG neuron. Very looks similar to the control condition. It means that NK cell should contact the NK cell, the DLG neuron to kill. And this is our live cell imaging. It's the Biol cell is the DLG neuron. The green cell is the NK cell. NK cell is very motile. One more time, you can get this cell body. You will see the urite here, right? Urite, right? This urite. The NK cell, they destroy all urite in this condition. This is embryonic DLG neuron, as I mentioned. What about adult neuron? This is a one day culture. NK cell try to kill. They use the contact, the urite, but they don't destroy. They don't destroy. They contact, but they cannot destroy. Very different. Embryo and the adult is very different. Why? Why is different? Then, as I mentioned, NK cell kill the aberrant, because the abnormal cells, right? The non-self cell, like the missing MH1, the ML class 1 molecule in the target cell. Also, NK cell has the activating receptor in the membrane, like the NKG2D, like NKG2D receptor. They bind to the target cell through the RE1, the ligand. If the target cell has the RE1 ligand, they can bind each other. Then the granzyme release. This is a cytotoxic granzyme enzyme. They can the target cells. Then we examined the RE1 expression and found that RE1 expression is pretty high in the embryonic Dlg neuron, not in the adult Dlg neuron. That's why in only target embryonic. Then we check the protein. Then embryo Dlg neuron has higher protein RE1 expression. And then we knock down the RE1 like this. Then the cytotoxicity decreased, significantly decreased, meaning that RE1 can bind to the ligand and then they can kill the target cell. Then we also did the calcium imaging. We found that this is the calcium imaging from the embryonic Dlg neuron and the adult Dlg neuron. They found that calcium level goes very high when they kill the cell. But in adult Dlg neuron, it's very low, right? Very low. That's why this is one of the reasons why the cell cannot kill the adult Dlg neuron. Then while we imaging the adult Dlg neurons, some condition we see that NK cell bind, they can destroy the neurite here. One more time, that you see, right? That the contact and then level goes high and then destroy. This means that even in adult neuron, they quite resistant to the NK cell, but in some condition, they can be targeted by the NK cell. Why they can target? Then we use the microfluidic culture. Is that we can put NK cell in one section. Then NK cell, the Dlg neuron grow very well. The neurite grow to the other side of the culture dish. Then we can put the NK cell in other side, the neurite side, and then compare the response. This is the control and then this simulation condition. You can see some difference here. There's a very dense neurite here, but after NK cell treatment, the density goes drop, right? The density drop means that now the NK cell target the neurite and then they can destroy the neurite. That means that explains our finding. Then why? This is from adult Dlg neuron. Why now they can target the Dlg neurite? Then for this culture, we culture 5 days, 3 to 5 days, the long-term culture. Then we found that during the long-term culture, RE1 expression goes high in long-term culture condition. Now then NK cell target the Dlg neuron, then kill the neurite. Then to confirm this one, then we knock down the RE1, but at the RE1 using the siRNA like this. This is the condition, and then we treat the NK cell, the stimulated NK cell. You see, if we knock down the RE1 expression in the Dlg neuron, now the NK cell cannot kill the Dlg neuron. This means that they need to direct contact the neurite through the RE1, the ligand. Then we confirm the previous result, and then now we decide to our finding in the in vivo condition. What happened after nerve injury condition? Nerve injury condition, probably RE1 maybe can be increased and be targeted by NK cell or not. For this study, we used 2 mouse strain, then NKp46 Cre the mice. This is the NK cell specific Cre line, and then we can cross with the YFP prox mice. Then now the the mice can be GFP is labeled for NK cell. You can see here, this is spleen staining. GFP stain the cell is the NK cell. Another is we cross with the TTR mice, the diphtheria toxin receptor mice. We cross, then NK cell now express the TTR receptor. Then we treat the diphtheria toxin. Then diphtheria toxin can kill the NK cell. Then we can remove the NK cell from the mice. TTR mice condition detect treatment, you see the NK cell is almost gone, right? No, almost no. Wild type you still see. Then we can remove the NK cell from the mice. Then by treating DTX, we can keep the mice over 1 month without the NK cell. Then we can study the role of the NK cell in these mice. Then we induce the peripheral nerve injury in this mice, and we now see the NK cell active, right? This is the injury condition. This is Jung model. 정진목 교수님 developed this model. In this condition, we check the NK cell, which you see here, BLG, and the sciatic nerve, you see the NK cell. So after 4 days, 7 days, now NK cell recruit can go to the injury site. Then now they can do something there. Then we also measure the RE1, right? RE1. We check the transcript RE1. Day 4 days was much higher in the injury condition. Then granzyme B. This is actual cytotoxic enzyme. Then granzyme goes high in day 4, day 7, and then in the NK cell ovulated mice, the granzyme level goes down, meaning the granzyme is released from the NK cell. They can degenerate, kill the injured fiber. That's our interpretation. Then we decide to the culture, the injured neuron. That we made a nerve injury in the mice and wait 7 days. Then we expect the RE1 expression goes up in this mice, and then we culture the DLG neuron from the mice. Then just 1 day culture. In this condition, we found that NK cell now they can destroy the neurite, meaning that after nerve injury condition, now already the RE1 expression goes high. Then now NK cell destroy and kill the neurite. Then you can see here fragmentation goes very high in this condition. Then we check the RE1 transcript level here. Then we can see the big difference, much higher RE1 expression, even just 1 day. Previously, without nerve injury condition, 1 day is very low, the RE1 expression. That's why NK cell cannot kill the adult neuron. Now, after nerve injury condition, we keep the mouse 7 days, then culture just 1 day. Now they can destroy the injured nerve fiber. Then we also made the site crush injury like this. Then in this model, too, we see the NK cell like this. It says 3 days, 4 days, 7 days. It's almost the same in the L5 transaction model, much higher the NK cell infiltration to the injured fiber, and then RE1 expression also goes very high. Almost the same result. This is the in vivo, the 2-photon imaging for the sciatic nerve. We image the injured nerve. This is NK cell. Green cell is the cell. You see NK cell move around. Like you imagine in our in vitro culture condition. This is move around and stop like this. We move around and then stop like this. We expect maybe it move around and find some pocket and stop. They try to remove the injured fiber. Then also this is a blood vessel. We also label, we imaged labeled NK cell. Then NK cell, image is not so good. We found that one cell is now come here, this one, and stop. We expect maybe they try to move out of the blood vessel to the injury nerve side. Then we also check the REO1 expression protein. This is the protein, also the in situ the mRNA the imaging in the DRG neuron. We found that mRNA transcript is expressed in the injury site, like this one. Contra is the no injury site, right? Then we don't see any the REO1 transcript here, but after injury condition, transcript goes up in the cell body. Then we check the protein, REO1 protein. It's very interesting. We found that we don't see any the protein expression in the DRG, like 3 days, 7 days. You see almost no expression like this, but only crush side the REO1 goes up. Protein. Even the mRNA is here in cell body. We expect maybe the protein goes to the injury site. That's why NK cell can go to that area and then specifically target the injured fiber. This is another image. We tie the nerve and then image the REO1 expression, protein expression. We found that REO1 expression is accumulated in this protein end. Then the final is we showed the phenotype, right? In vivo, what they do, right? What they do. We know the NK cell goes there, and what they do there. Then we did some behavior study. Then first thing we did the sensory recovery test, and then we made the crush model. Crush model is very simple. We can just crush the nerve fiber like this, fully crush. Then we can destroy the fiber, and then it took about 2 weeks like this. About 2 weeks, it recovered to original level. It takes 2 weeks. Then what they do is that we check the sensory recovery by stimulating the hind paw like this. We made a 5 area in the paw, and then the A, B, C, D, E, and then we can give it the point 0, 1, 2. 2 is the full response, 0, no response, 1 is in the middle. Then full recovery means 2 multiply 5 is 10. 10 is the full recovery. Then after full crushing, it took 2 weeks, right? Then it took 2 weeks, and we deplete NK cell by treating the DTX. We found that the sensory scores goes up. Not so dramatic, but we found some phenotype. What this means? This is the regenerated fiber. We don't think that, because it's too early to show the regenerated fiber function. And we think that maybe NK cell target the injured fiber. Then when we deplete NK cell, they cannot target the injured fiber. That's why some fiber is still functioning, right? That's why we see some like the score like this. It's very hard to understand. Whenever I explain this one, it's not easy to follow, but this time I will show another data to explain this one, right? Then what is the NK cell role in the peripheral nerve injury condition? Then we imagine that nerve injury condition can be like this, partially injured conditions. Then we made the injury condition, full crush and then partial injury condition. The full crush, it goes from 0 to 10 in 2 weeks. Then we made a partial crush. Partial crush means that we made a gap, about 30 micrometer gap. Crush, but it is gap. That's why we cannot fully crush it, meaning that if no fiber is not completely damaged, some fibers still remain, but partially they are damaged, right? In this condition, what we did is we stimulate the NK cell in this condition. Then we check the pain response after nerve regeneration condition. In 2 weeks, nerve fully regenerate to the target, and then day 16 and day 30, we check the pain response in this mice. We found that only partial nerve condition, the mice show the pain hypersensitivity. Full crushed mice doesn't show the pain response. This is threshold. Threshold is much lower in the partial crush condition in day 16 and day 13. Then we stimulate NK cell with IL-2. We found that this level goes up. meaning that now the pain can be reversed by targeting by using the NK cell. Then and blocking the NK cell with the antibody, NK 1.1 antibody. Now we see the pain response, meaning that we can target by using NK cell, we can target the injured fiber, then we can reduce the pain response. This data show that. Then I will show what happened in the nerve fiber after NK cell stimulation. This is we use the IL-2 antibody complex. Then you see here, you see many the green NK cell here, right? After NK cell stimulation, NK cell goes to the injured side. It's much higher number here. Cross side and even the distal side, you see much higher number of NK cell. Then in the partial crush condition, we inject NK cell. Then we the early time point, we found that the sensory scores go down because the NK cell are destroyed the injured fiber. Then when you stop, it goes up, and then recover. Then now we think the NK cell that is targeting the injured fiber. Then stopping, then it goes to the. You see here that even in the same condition, the recovery time is the same. We believe that the NK cell doesn't affect the regeneration process in. Then when you block the NK cell with the NK 1.1 antibody, we can reverse this response. It means that this response is quite specific to this. Then this is the immunohistochemistry data. This is crush condition. Crush means, as I said, it's just crush like the nerve fiber. Then crush, you see the nerve fiber is now thick, right? Much thicker than this one. This is the but some the inflammation even they can show by this crush condition. Then you see the very dense nerve the immunoreactivity. Also, we scan with the STEAM and put this as nerve injury marker. We found that this injury markers also was higher in the crush condition. Then we treat the IL-2 anti-IL-2 complex to activate the NK cell. Now we see that this increase the densities go down by this treatment. We think that now the injured fiber is targeted by the NK cell. Now we see much less intensity of this injury fiber, the immunoreactive. Then this is the summary. Already 35 minutes. This summary. This is the partial nerve injury condition. NK cell is the extravasate from the blood vessel to the nerve injury site, and then they find the target. They can only target injured fiber, not the intact fiber, because injured fiber express this rare one ligand, and the NK cell have this engaged receptor. They can physically bind. We call this as neuroimmune synapse. Then the granzyme can release, and then they can remove this regenerate this injured fiber. That's our finding. We published this work in 2 years ago. Then this is our working hypothesis. Then, as I said in the introduction, that neuropathic pain results from the nerve injury. In nerve injury condition, damaged nerve like this, right? Some nerve fiber damaged like this. Then they can make some signal there. They can induce some ectopic discharge. They express some more the ion channel in the related with the neuronal excitability. Then they fire more. That's why they can induce the pain in the patient. Then they cause the pain like this. Then when the nerve is completely injured, like full crush condition, in this condition, nerve can regrow, right? As I said, peripheral nerve can regenerate. They can regenerate. They can fully regenerate. That we call the Wallerian regeneration. They can target. Right, like this. But here, the some fiber still remain. We think that some fiber still remains, not fully degenerated, but still, in many conditions, they remain. This is still making some pain signal. That's why they cause pain in the pathological condition. This fiber can be targeted by NK cell like this, because they express the NK cell ligand. Then we treat NK cell, it goes there, and then it clear. Then now when removed, and then now probably NK cell, after NK cell function, the healthy fiber can grow to the target. Now functionally fully recover. That's our working hypothesis. We are still working on it. This is true or not, but we are now having quite interesting more the results now. Then we present this the finding. Then let's see. Then I will about 10 minutes. I will about 5 minutes. I will just show some of the recent work about what was going on in our lab. Then we found very significant difference between full crush and the partial crush, right? That is like this. This is a full crush condition.